Today I'll be sharing with you some preliminary results from our project on health system resilience during COVID-19. I'll be presenting for about 10 minutes and then we'll have a panel discussion with 4 collaborators on this project. So let's get started. So during a time of crisis, such as the current pandemic, high quality health systems have 2 tasks: to respond to COVID-19 and to maintain essential health services. Evidence from past health crises, such as Ebola epidemics, have revealed that many health systems lack resilience during shocks, such as the current pandemic. So at the beginning of the pandemic, we knew that it would be important to try and monitor health services in real time in an attempt to try and minimize the indirect effects of the COVID-19 pandemic on health systems. So for these reasons, the QuEST network designed a project with 2 aims. The first was to estimate the effect of the pandemic on service utilization, quality of care, and institutional mortality from non-COVID conditions. And the second aim was to develop methods for cleaning and working with routine health information system data, so HMIS and data from DHIS2 platforms. And 2 sub-aims were to build local capacity to work with these data that are vastly underused, and also to provide recommendations to improve data quality. So we launched a call among QuEST network collaborators, and colleagues in 10 countries responded. So our project now includes data from 10 countries, including Mexico, Haiti, Chile, Ghana, Ethiopia, KwaZulu-Natal in South Africa, Nepal, Thailand, Laos, and South Korea. So I want to mention that our project began in June 2020, so almost a year ago. And we collected data until the end of the year 2020, so until the end of December. But I want to mention that a lot of our colleagues are facing now worse COVID-19 outbreaks in 2021, unfortunately. And we like to thank them for their hard work during these difficult times. So the first thing we did for this project was to work with our partners to extract data from routine health information systems for the period of January 2019 to December 2020. That includes 15 months before COVID approximately, and 9 months during the COVID pandemics. And we were able to extract as many as 47 different indicators across the 10 countries, although not every indicator is available everywhere. We included outpatient visits, emergency room visits, and inpatient admissions, which are summative indicator of health system utilization. We also included several indicators on reproductive, maternal, newborn, and child care, including vaccinations, on TB, HIV, malaria, screening and care, chronic disease, care and injuries. And we tried to also include indicators on quality of care, though those are a little bit harder to find, but we did find 2 examples here are the proportion of asphyxiated newborns who were resuscitated and survived, and the proportion of diabetic patients with controlled blood sugar. We also were able to extract data from institutional deaths, inpatient trauma, maternal deaths, newborn deaths, and stillbirths. So the next thing we did was to conduct some extensive data cleaning in countries where we had facility level data. So we imputed certain missing values, we identified and removed positive outliers, and we performed a complete case analysis, more or less, by excluding facilities with sparse reporting. And so this code, once it is finalized, will be shared publicly on GitHub for everyone to be able to access and use. We also created dashboards to be able to detect disruptions in real time. Here we're seeing an example from Mexico with the complete dashboard with data for 2 years. And what we're seeing here is the number of people who came in for diabetes and for hypertension consultations. At the bottom, the thicker lines are the trends in 2020 compared to the trends in 2019 in thinner lines. So we are planning for 4 papers, 4 multi-country papers to come out of this project. The first one will look at the effect of the pandemic on service utilization in 10 countries. The second will describe quality of DHIS2 data in 5 countries where we have access to facility level data, and describe our methods for cleaning the data. The third will look at the effect of the pandemic on institutional mortality. And the fourth will investigate the potential determinants of these disruptions. And we're also hoping for a national paper in each of the 10 countries to be able to investigate some national differences and address other country-specific questions. So here I'm showing just a brief overview of some preliminary results. Here we're seeing facility deliveries over 24 months in 9 countries. And the red line is the trend pre-COVID, which is extended into the COVID period. And the blue line is the observed number of women who came in to give birth. And what we're finding is that of these 9 countries, there are substantial reductions in the number of women who come in for childbirth in Haiti, in Mexico, in Nepal, as well as Chile. So the reasons for these disruptions probably differ in different countries. Here I also just wanted to show you a second example, which is tuberculosis screening and TB case detection. Here on the upper left side is the number of people screened for TB symptoms in KwaZulu-Natal. Starting March 2020, we see a big drop in the number of people screened. Same thing for the number of TB cases detected in KwaZulu-Natal. At the bottom left in Ghana, we also see a big decline in the number of TB cases detected. And in Nepal, it's less obvious, but there is still a small change in level. So I'd like to thank all our collaborators on this project, including colleagues in 11 different countries and the research team at Harvard.